Doing perineal massage before the onset of labor, some people do recommend. I don't. The evidence supporting that is not very strong. The studies are not the greatest. If you do decide to do it, make sure someone instructs you on exactly how to do it. And I would not start doing it before 36 weeks of pregnancy. Now here is a picture of how to do antenatal perineal massage. And here are the steps. And this is a picture showing how you would do it to yourself, but your partner can do it as well, if that's what you want. Pause to read. Now, the evidence is stronger on perineal massage while someone is pushing or during the labor and delivery process, particularly if you are using warm compresses while doing the perineal massage. I imagine in centers where the nurse is primarily doing the pushing until the obstetrical care provider comes in, that they would probably do it as well. So let me show you how I prefer to do perineal massage when someone is pushing. So, quick anatomy lesson. This is going to be the labia. All this is the vulva. I'm going to tilt this up here. That red dot would be where the anus is. And then the area between the introitus, or opening of the vagina, to the anus is that thick piece of tissue there, is the perineum. So that's why it's called perineal massage. What you can see here is a little bit of the fetal head coming through, and the labia start to separate as the fetus is coming down. Now, before anybody says anything, of course my hands would be gloved, and I would not have all this on. But when you do perineal massage, I typically just do pressure, and I always do 2 fingers together, because I found that if you just do 1 finger, and this is how I teach my residents as well, down through the vaginal vault on either side is something called the sulcus, and if people put too much pressure like this, I find that it can cause sulcal tears. So when I'm teaching residents how to do perineal massage, I always tell them to always keep 2 fingers together. So I would go down to the perineum, and I just kind of hold pressure to kind of push down and help to stretch that out. What I don't do is a lot of this, rubbing back and forth, because all that does is cause abrasions on the inside of the labia and also on the perineum, and that can increase the risk of tearing and cause a lot of just extra bleeding that doesn't need to be there. So the less of this we do, in my opinion, and with my expertise, I've been doing this a long time, the better. So the way I teach my residents is as the fetal head starts to crown and the labia start to separate, sorry, this is really hard to do, then I will put 2 fingers in, I will hold pressure. This also, I find, when the patients can feel that increased pressure there, especially those who have never pushed before, they know where to direct their energy because they'll feel a little bit more pressure there. But again, I don't do a lot of this rubbing here because I don't want to cause extra tearing, and that can also increase the tearing of the labia. And so I just give that pressure there to help direct the patient as to where to push, and also to give a little bit of extra room. I always use 2 fingers instead of 1 to prevent those sulcal tears down into the vaginal vault. Now, while we're at it, I'm going to talk to you about where people can tear. The most common places that people can tear, what you hear about the most, are the perineal tears, which occur in this area here, or they can occur off to the side. When you do an episiotomy, they can be a midline episiotomy or a right medial lateral or left medial lateral episiotomy. People can also tear on the labia majora and labia minora, which would be on the inside. This model doesn't have it. If the clitoris is up here, then if you were to pull back the labia, there would be the urethra right underneath there. I've seen people tear straight up through the clitoris, and even through the urethra. I've seen them tear around it. I've seen all variations of tears of the labia. I've seen it all. And you could also tear in the vaginal vault, again, down the sulci on either side, or on the side walls. You can tear anywhere. Not to try to scare anybody, but just remember, if you tear, ask your provider where exactly you tore, so you know where you tore. It does not matter how many stitches you get, because we most of the time do a running stitch. So it's not like we're doing 1 stitch at a time. So the number of stitches does not matter. You need to know, did I have a perineal tear? Did I have a vaginal vault tear? Did I have labial tears? Did I have periurethral tears, periclitoral tears? Where did I tear? So that you know where to focus on and inspect once you get home. One last thing for the clitoral tears. It's very important that any periclitoral tears or tears that go through the clitoris, that you don't take that needle through the clitoris or too deep on either side, because there's very important nerves there that you don't want to damage. So I just do the skin back together, because largely those tears do not bleed. I just put the skin and the anatomy back together. I don't throw deep stitches because you don't want to do any additional damage. And then also, as you're repairing that area anywhere around the urethra or the clitoris, you got to put a catheter in so that you know that you're not going into the urethra. So I know that was a long video, but I hope that cleared up some questions.